Hey, good morning. Sorry about that. Ooh.
Hello, Dr. Evans. Would you like to test your presentation real quick? Oh, you're muted.
Yeah.
Let me open it right now for you, okay? Where'd it go?
Oh, I can't hear you.
Can you hear me now?
Not now.
Not now?
I
Do you have a
can
volume
hear
button?
her. I can hear her, Ray. Can you hear me, Ray? Huh.
Yes,
I can
Andrea.
hear you.
Yeah, we're hearing it. Let me tell him 1 second. Uh, Ray, we all can.
Let me
Lauren.
figure out the best way to do this.
So you want to get your presentation open and then use the share button at the bottom?
Yep. I'm just trying to figure out the best way to make it as big as possible. That's
Oh, I
all.
see. Okay.
There we go. That should work. All right. How's that, guys? I can probably go into presenter view too.
Yes, please.
Um, where did it go? Good.
Could you make it a little bigger if you want? I mean, but it's
This is about as big as it gets because I'm in presenter mode.
that's fine. Looks good.
Okay, great.
Perfect. Thank you.
Yeah, absolutely.
Dr. Evans, you have a whole bunch of polls, and when they appear in your presentations, I will present those on screen for you. And then the people who are attending can give them a couple minutes to a couple seconds to answer the questions and then discuss that, and then we can move on to the next one.
Perfect. That sounds great. Thanks,
Okay,
Ray.
thank you.
Good morning, everyone, and welcome to our International Colorectal web meeting. Today, so far, we have pediatric surgeons joining from Chile, Algeria, Mexico, United States, Argentina, Peru, Pakistan, Brazil, Egypt, Kenya, Sri Lanka, Trinidad and Tobago, India, Russia, Honduras, Yemen, and Czech Republic. If I did not mention your Libya and Palestine and Colombia. So if I did not mention your country, please type in the chat and I will acknowledge at the end. So the first presenter today is Dr. Ana Cristina Castellanos. She is a colorectal fellow at Instituto Nacional de Pediatría in Mexico. So welcome, Ana Cristina.
Hi, good morning. Could you see my...
Yes, it's perfect.
Okay.
Thank you. Here we go.
We present the case of a 7-year-old boy originally from a rural town from Guerrero, an underserved area where his mother did not have access to prenatal care. He was born at home with the assistance of a midwife. At birth, he was not examined by a physician and he did not receive any medical care. Nevertheless, he appeared to grow up healthy. At the age of 1, his father began seeking medical care due to the boy's chronic constipation. Laxatives were prescribed. At the age of 6, he was diagnosed with malnutrition and moderate intellectual disability. He was started on laxatives again, without improvement. He required to be admitted to the hospital for fecal impaction twice. He was referred to our institution because intractable constipation. The relevant points from the clinical history include: he passed meconium within the first 24 hours of life. He had bowel movements once a week, which improved to twice a week with laxative. He frequently experienced fecal pseudo-incontinence, and the rectal exam at the clinic was not feasible because the patient was non-cooperative. At his first visit clinic, we review a contrast enema done at the referring hospital, which showed a megarectosigmoid with abundant residue and a decreased caliber of the lower part of the rectum. We perform an exam under anesthesia to assess the anus, and the largest Hegar dilator we could pass was 8 millimeters. The clinical stimulation showed the orifice outside the muscle complex, so the patient had an anorectal malformation with a perineal fistula. So, what would you do? A. A colonic irrigation and rectal biopsy. B. An urgent colostomy. C. Fecal disimpaction. D. Sigmoidectomy. Or E, B, and C are correct. Okay, so most people choose the option E, that is B and C are correct. We complete assessment to rule out other Bacter anomalies, yet the only one found was the anorectal malformation. Our decision was to perform fecal disimpaction and a colostomy. During surgery, we observed a megarectosigmoid and bladder distension up to the umbilicus. 24 hours after colostomy, he initiated oral intake. The patient remained stable and showed no signs of acute abdomen. 1 week later, the father requests the surgical correction of his son malformation, and due to the family's socioeconomic condition, we decide to proceed. We perform a PSR with a rectal tapering using an 80 millimeter stapler. The anus was calibrated with a Hagar 15, and clear liquids were initiated in the postoperative. 2 weeks after surgery, we began rectal dilation using a Hagar 15. At the next visit, we increased the size to Hagar 16. 1 month later, we performed a colostomy closure and sigmoidectomy using a linear stapler. These are the intraoperative pictures we captured. 2 weeks after surgery, we start Senna and gradually adjust the dose. He is currently taking 5 tablets of Senna daily. Thank you.
Thank you very much, Dr. Ana Cristina. Can you go back in the slide, the initial X-ray post-op? I just want to show something that I think it's interesting.
This one?
There, yes, yes. So it almost gives the impression that there is a mass you can see around. I don't know if you can show that it's probably the huge bladder that he has. Do you see that there is the bow, it's kind of push, and there is a level there? I don't know if I don't think you can see my arrow, but it's almost probably this is the bladder. And we have seen patients that have severe constipation and also have large bladders. So it's important to have this patient evaluated by urology to study this bladder, because sometimes even treating the constipation does not necessarily give back the normal bladder. So I think the key here is the size of the anus. If there was a perineal fistula, but the patient is already old and the size of the anus is good enough, I don't think the repair of the perineal fistula per se would improve constipation, because we always say the repair of the anorectal malformation does not treat constipation. Those patients already have a severe constipation, but obviously they need the right size caliber of the anus. So it's unfortunate that this patient had a late diagnosis and developed such a megarectum and such severe disease that required way more surgery than if he was diagnosed early in life. And I think that's the hard malformation to diagnose for those that are not familiar and for those that don't suspect the disease. Do you want to comment? Any other question or comment?
I
Go
just
ahead.
want to say that we did the urology
Evaluation?
evaluation, and the kidneys and the bladder was normal.
Yes, yes.
Yeah.
Okay. I would say, I don't know if he did urodynamics, because probably he has a very large bladder. So, but the fact that the ultrasound is normal, it's very reassuring.
Okay.
Any other questions or comments?
You mentioned that the patient is taking Senna laxative, and but I'm assuming that she's having voluntary bowel movements and having no soiling. Is having voluntary bowel movements every day and no soiling? Did I understand that well?
Yeah, doctor. He's having bowel movements voluntary, and he's not soiling.
Wonderful. Very good. Congratulations.
Thank
So
you.
there is a question about when should Hager dilator be started after PSARP. Our recommendation is 14 days after surgery, and we do it in clinic. Of course, when you operate on a bigger patient, this is a harder task. So when we operate on bigger patients, we try to make the anus a little larger because some of them just don't tolerate dilations. Thank you, Anna. You can stop
Yep.
sharing. And the next presenter will be Dr. Lauren Evans, who is the Colorectal Fellow at Children's Hospital, Colorado. So welcome, Lauren.
Thank you. Okay, good morning, everybody. I'm going to be presenting a few cases that have some interesting parallels. So the first case is a 7-year-old female who had a lifelong history of constipation and had been taken to the operating room for fecal disimpaction 3 times in the last couple of years prior to presentation. Her past medical history was notable for mild developmental delay, primarily related to speech. In the emergency department, she presented with no bowel movement for about 2.5 weeks. They had attempted a home Miralax cleanout, which for the last few years she had required once a month or so, but that had resulted in only mild, very temporary improvement. At the presentation, she was tachycardic and ill appearing. She had a distended tympanic abdomen, but no peritoneal signs. At an outside hospital, she had undergone a CT scan of the abdomen and pelvis, which demonstrated severe fecal impaction and stercal colitis in the sigmoid and rectum, for which she received fluid resuscitation and was started on Zosyn or piperacillin tazobactam. Here are just a few representative images. I saw Dr. Bischoff's face. Representative images of her CT scan, and you can see the scout film for the CT in the top left corner. So it was very severe. And in this lower image, you can see the thickening of her distal colon, demonstrating the stercal colitis. So she was taken to the OR by our general pediatric surgeons, where she underwent disimpaction and a rectal biopsy. She had a large hard stool ball in the rectum and a lot of liquid stool above and a very redundant rectum. She ultimately was admitted to our gastroenterology service, was started on a Go Lightly cleanout, and her antibiotics were continued. At that point, colorectal surgery was consulted specifically for enrollment in a bowel management program. We were reported that she had failed a laxative trial, and we were asked to please advise on an enema recipe. So what would you do next? And what are you concerned about? I think this is undiagnosed Hirschsprung's disease. Wait for rectal biopsy results. This is probably chronic constipation. She needs urgent enrollment in bowel management for initiation of rectal enemas given the stercal colitis. Or I'm not sure yet. I think I need to know more about her stooling habits and history. Okay, interesting split. I don't want to give it away. So when we went and evaluated her, this is what we saw. So some additional history. She had not passed meconium for 48 to 72 hours of life. She was suffering from pretty significant malnutrition and poor weight gain. At the age of 3, she was in the 17th percentile, and by the age of 7, she was less than the 1st percentile. So she was falling off her growth curves pretty significantly. She did have a strong history of oral aversion and picky eating, for which she'd actually seen several therapists in consultation with failure to improve despite eating therapy and things like that. She had been hospitalized multiple times for fecal impaction. All of those hospitalizations were associated with significant abdominal distension. She had been ill appearing, multiple rounds of emesis, and all required antibiotics. She did have a history of encopresis with lots of stool-filled underwear, but she had toilet trained successfully for urine. But the max laxative dose that had been attempted was only 10 milligrams of senna. And you can see there on physical exam, she was a very small child, but had a very large abdomen. So does this change your suspicions? What next? I still think this is undiagnosed Hirschsprung's disease. Wait for the results of the biopsy to confirm the diagnosis, but we should start irrigations and plan for a pull-through. Still think this is undiagnosed Hirschsprung's disease. Wait for the results of the biopsy, start irrigations, but we should get a contrast enema first to look at the length of her disease. I still think this is consistent with untreated chronic constipation. Her poor weight gain is likely a separate issue, and she needs a bowel management, but with laxatives, because she hasn't had much of a laxative trial yet. Or untreated chronic constipation, her weight gain is a separate issue, urgent management with rectal enemas. Okay, so we very much agreed. I think the big giveaway here for us was her history and then also her significant malnutrition that we thought was probably related to a history that sounded like underlying chronic untreated enterocolitis. So we waited for the rectal biopsy results, which demonstrated that there were no ganglion cells identified. She did not have any nerve hypertrophy. The calretinin immunostain was negative, and the GLUT1 immunostain was negative, but there was insufficient submucosa. So this was suggestive of Hirschsprung's disease, but given the insufficient submucosa, was overall considered non-diagnostic. So based on that, what would you do next? Schedule for a repeat biopsy, proceed to the OR for leveling biopsies and a pull-through, or obtain a contrast enema, and pending the results of the enema, determine if she needs a repeat biopsy.
Just a few more seconds here.
Interesting. Okay, so we chose to obtain a contrast enema first, and based on the results of the contrast enema, decide if she needed a repeat biopsy. The thought process there was that if the contrast enema was congruent or consistent, also consistent with Hirschsprung's disease, because the biopsy was suggestive of Hirschsprung's disease and the contrast enema was suggestive of Hirschsprung's disease, we would proceed with diagnosis that way. The plan was that if her contrast enema was not consistent with Hirschsprung's, that we would rebiopsy her after that. So this is her contrast enema. And based on this contrast enema, what are your thoughts? This is short segment disease. This is probably long segment disease with a transition zone proximal to the rectosigmoid. This is consistent with constipation, or not sure. Yeah, we agree. So we thought this was very consistent with short segment Hirschsprung's disease. So how would you proceed, or how would you manage this patient? Would you do a pull through with a diverting stoma this admission? Do a pull through without a diverting stoma and a gastrostomy tube given her malnutrition? Or start irrigations 3 times daily and prophylactic flagyl, plan for discharge home, and then pull through at a later date? Great, so we agree with most of you. So we started her on irrigations 3 times a day, as well as oral flagyl, 10 milligrams per kilogram every 8 hours. The gastroenterology team placed an NG tube just to do supplemental tube feeds overnight to support her nutrition. And then we planned for close follow-up at clinic. The theory being that with the irrigations and the flagyl, the kind of chronic smoldering enterocolitis that was contributing to her malnutrition and poor oral intake would improve. And then we plan to do a pull through at a later date once her malnutrition had been addressed and her nutritional status had improved. So when we saw her about a week after her initial discharge, while she did have a stool burden on her x-ray, she did not have any signs of ongoing enterocolitis. She had an excellent appetite with a significantly improved oral intake. Her picky eating had resolved. She continued to show, or she started to show good weight gain and had started to go back onto her growth curve. Her NG tube was actually going to be removed at a subsequent appointment, and we'll plan for OR in probably coming months once she has improved on her on her malnutrition. That's case 1. Dr. Bischoff, Dr. Pena, any comments?
Yes, I think it's very interesting. It's very rare for us to see such a late diagnosis of Hirschsprung. And just looking at the picture of how malnourished she was, that's what should ring the bell that this is not just a case of constipation. So I think when you place the questions of what are the options, we missed to give one more option to open a colostomy, because I think that would have been what many people would have done in a case like that. Open a colostomy and then work on her nutrition status and then do the pull through. And the only thing that concerns me is because when you have those Hirschsprungs that present late in life, they are usually very short segment. They usually don't have much history of enterocolitis. They are kind of the benign Hirschsprung, and that's why the patient has survived. So they almost behave as a severe constipation case. And I think the only thing that concerns me on this wait until the next step is this X-ray shows a lot of constipation.
Yeah.
So I think the irrigations, they are very good for liquid stool, but when you have solid stool, the irrigations are not as good. So that would be my only comment. Do you want to comment anything?
Yes, I don't know if I understood well. The rectal biopsy was taken before the contrast enema.
I'm sorry, Dr. Pena, you cut out for a second. The rectal biopsy was taken before what?
The contrast enema.
Yeah, so the surgeon, the general pediatric surgeon who addressed this in the middle of the night when she presented with colitis on the CT scan, has a practice where he biopsies everybody. So she was empirically biopsied when she was disimpacted.
So you show a very spectacular, I think it was a CAT scan or MRI, the dilated bowel. I would do a contrast enema. That would be the first thing to do in this patient.
Yeah.
And with the contrast enema, we'll have the diagnosis already. And then I will take the biopsy to confirm that. And concerning the main treatment, once you clean the colon completely, of course, will be your choice to decide to go to do a pull through and resection of the most dilated colon. In other words, if the most dilated colon has a very poor motility and doesn't work very well, so I will do the pull through, resect the ganglionic segment, and resect the very dilated colon, and then pull through of a decent size caliber colon. And whether or not to do a colostomy will be the surgeon's preference and how confident the surgeon feels with this kind of procedure.
Dr. De La Torre?
Yes, I agree and disagree with Alberto in this case because if in this case the patient had a biopsy and we received the report very soon, I want to say in the next 24 hours from the biopsy, and I want to address here that based on this not very clear histopathological report, my recommendation was to do like a second opinion. So I went to the pathology lab and review with the seniors, from experts in the hospital, this biopsy, and there is no doubt about the diagnosis. The amount of glucosa was enough, different from the original report. And at the end, the diagnosis of Hirschsprung was confirmed, at least histologically. If we, in the scenario that this patient, we start doing the contrast enema before the rectal biopsy, most probably, the radiologists, they are going to do a contrast enema without the adequate technique to diagnose Hirschsprung disease. So when I did, because I went to the radiology department and I did personally the contrast enema, it was amazing how the contrast, the transition zone, the radiological transition zone was demonstrated. So probably the good looking for this patient that the surgeon took the biopsy and then we confirmed the Hirschsprung disease. In other scenario, most probably the surgeons just, or the GI, they do the rectal disimpaction and then go lightly. And nobody's going to take the biopsy and this patient will be again and again in the hospital. That's why I think in this case, the good point for the surgeons to take the biopsy and confirm Hirschsprung allows the colorectal team to do the contrast enema, which is our recommendation.
Very good. Any other questions or comments from the audience. There is one question. Is it important to comment on the presence of stratified squamous epithelium in a biopsy report? That's a good question. Dr. De La
Yes.
Torre?
Yeah, it's a very good question. Yes. Now, the biopsy was obtained from the rectum. We review all the slides and all the 65 sections, and all of them has a rectal mucosa and enough submucosa. So the original pathologist was, let's say, not a good pathologist, honest. He was very honest, or she was very honest. And that's why we went back to the pathology lab and request a second review with the senior pathologist. And yeah, there is no doubt about the biopsy.
Good. And in those cases, it's just important to ask the pathologist to amend their report. So it's documented in the medical chart that this review happened.
And I just want to add a little thing. The most recent X-ray is not this one. The most recent X-ray is much better. It's practically normal without poop. Thank you.
Wonderful. Okay, Lauren.
Okay. Next case. Well, this is case 3/2, I guess. So similar, another 7-year-old female, also with a lifelong history of constipation, actively followed by our gastroenterologist for constipation, who had immigrated from South America as a child, or as a baby, I should say, presents to the emergency department after undergoing a contrast enema 2 days prior, under the instruction of the gastroenterology team. She presented with abdominal distension, pain, multiple rounds of non-bilious, non-bloody emesis, but she had not passed flatus or had a bowel movement since her contrast enema. Her abdomen was distended, mildly tender. She had no peritoneal signs, and did have a normal anus on exam. On the left-hand side, you'll see a contrast enema that was obtained by the gastroenterology team. And on the right, that's her X-ray actually 2 days later when she presented in the emergency department. So you can see an impressive amount of retained contrast, some pretty significant gaseous as well as liquid distension of the colon. Yeah. So what would you suspect and what would next steps be? Undiagnosed Hirschsprung's disease, plan to admit, start irrigations and a rectal biopsy this admission. Probably chronic constipation, needs enrollment in bowel management, or not sure yet. I need to know more about her stooling habits and history. Okay, I think we're leading everybody towards Hirschsprung's, I think, from the first case. So some additional history. She passed meconium at 4 days of life, and only with rectal stimulation. At that time, a rectal biopsy was recommended, but was never obtained, and then they immigrated to the United States. She only has a bowel movement every 3 to 4 weeks, but does not have any associated systemic illnesses, has not required hospital admission, and has no history of fecal impaction. She has suffered from lifelong constipation, for which she was being treated with just 1 capful of Miralax daily. From the ER, she was admitted to pediatric surgery. We did start irrigations 3 times per day, and we put her on prophylactic flagyl at 10 milligrams per kilograms 3 times daily. And she was taken to the operating room for a rectal biopsy, which demonstrated no ganglion cells, no hypertrophic nerves, and was consistent with Hirschsprung's disease. So how would you manage this patient? A diverting stoma this admission and plan for a pull-through at a later date, a pull-through this admission, or discharge home on rectal irrigations and prophylactic flagyl with plan for an elective pull-through in a few months. Okay, so either a diverting stoma or a plan for a delayed pull-through in a few months. And I think both are fair answers to that question. What our plan was is that we did not feel that her colonic and rectal distension was so significant that it required a stoma. So we had planned to discharge her home, or she did discharge home on irrigations 3 times a day, as well as oral flagyl. and very close interval follow-up in clinic with an abdominal x-ray, and she's been seen about weekly since her discharge from the hospital. And we plan to do a pull through about 6 weeks after her discharge from the hospital, and we'll plan to do a transanal pull through with leveling biopsies at that time. And that's case number 2. Any comments?
Can we show the contrast enema again?
Yes, definitely.
Where were those contrast enemas done?
So this was contrast enema. This was X-ray after
2 days
the
later.
contrast enema.
So and what was it that those studies were done here in Denver?
Yes, so the contrast enema was done by our radiology department as an outpatient, and was concerning for Hirschsprung's disease. However, they had not reached out to the patient to discuss the findings or had planned for intervention or follow-up at that time. And then she represented 2 days later with failure to evacuate pretty much any of the contrast. And the X-ray from her ED presentation is on the right side of the screen.
Yeah, because this study showed the contrast everywhere in the colon, and a good study starts by passing the tube and passing contrast material little by little to see the transition zone. And
Yeah.
here, these images were taken after. These are not with the image in the right side.
Yeah.
You cannot make a diagnosis. And the left side, yes, there is a narrow portion.
Yeah.
But in the right side, is I don't know why they took that X-ray. But anyway.
Well, so the left, this is the contrast enema here, and you can see the small rectum and the dilated sigmoid proximal, and then this is actually her ER X-ray 2 days later.
Yeah, I think it's just unusual to have
Totally.
unusual and sad to have such late diagnosis, and it's almost interesting, but the 3 cases presented so far today are 7 years old of diagnosis that should have happened very early in life. So it's almost as a failed medical system. How did we fail those patients?
Yeah, I agree.
And I'm saying we didn't see those patients before, but just it's a warning for all of us on how can we do better so those patients don't come so late to present to us.
Yeah. Okay, next case. So this is the last case I'll be presenting. A 9-year-old male, previously healthy, also with a history of constipation, if anybody's realizing a trend here, who had recently immigrated from Africa. He presented to our emergency department with a 2-day history of abdominal pain and non-bloody diarrhea. He was afebrile, had no sick contacts, had not reported any emesis, though his family was concerned that he had decreased PO intake and some signs of dehydration. He had a benign abdominal exam, was overall well-appearing and well-nourished, and had a normal anus. A little bit more history. We were told he had always been constipated. His underwear was always filled with poop per grandmother, though he only had a significant bowel movement every 3 to 4 weeks. The stools that he did take in the toilet were small and took a long time to pass. He was toilet trained for urine and didn't have any urine accidents in his underwear. They were unsure of when he passed meconium as a newborn and had been treated with multiple medicines for constipation while in Africa, though his family was unsure of which medications and the dosages of those. So with this history, what would you do first? A rectal biopsy, a contrast enema, or not sure? Yeah, so we agreed. Although there's been some back and forth in the discussion, we chose to proceed with a contrast enema first. And you can see some representative images of the contrast enema here and here. And so then based on this contrast enema, would you biopsy the patient? Yes, no, or not sure. Yeah, so we agree. We also chose to biopsy the patient. Now, the formal read from radiology for the contrast enema was that it was really considered an equivocal contrast enema. They were not able to fully determine whether this was megarectum or something consistent with Hirschsprung's disease. Their concern was this kind of turn you can see here where the red lines are. We weren't able to tell if this was simply a bend in the colon that was overlaying itself that made it look wider at that junction, or if this was a true transition zone. And so because it was equivocal, we really felt like it was mandatory to biopsy him to definitively rule out Hirschsprung's disease. So we took him to the operating room for an open biopsy or transanal open biopsy. A really important technique that Dr. Bishop, Dr. Pena, Dr. De La Torre teach is that when you go to put the Lone Star in, you can see here initially when you place the hooks to be able to do the biopsy, you place them fairly superficially, specifically to be able to identify the dentate line here, which you can see kind of where my cursor is. And then a big step is to then place the hooks deep to the dentate line to protect the anal canal to ensure that you are taking a biopsy adequately and in the rectum truly. We then place a suture proximally and distally to mark out the areas of our biopsy. The vicryls here at the proximal and distal margins are then used to close the biopsy. The silk marks the center of the biopsy, which is then taken with a scissor and sent to pathology. And then you can see here the vicryl running proximally and then back again, proximal to distal to close the biopsy. And then the patients get a digital exam to make sure that after it's closed, there's no area of narrowing after the biopsy. So in terms of his management, his biopsy ultimately came back negative for Hirschsprung's disease. So he was enrolled in our bowel management program and initiated on 60 milligrams of Senna every night. And you can see on the right-hand side, significant improvement in his x-ray at his follow-up appointment. And he's otherwise doing very well. He's having daily bowel movements and has not represented to the hospital. So that's what I have.
Thanks, Lauren. This one is my patient, the last one. So I have to say, when they consulted, just with the story that the patient had encopresis, I said, this is not Hirschsprung. I hadn't even seen the patient, and I said, I doubt this is Hirschsprung. And then I looked at the patient and I saw a healthy looking patient. So I was like, this is not Hirschsprung. Then we got the contrast enema, and I'm like, I don't love this contrast enema. I don't think it's Hirschsprung. But once the radiologist put that question in the operative report, and when we have an abnormal image, this was not, for me, a classic constipation in which you see that gigantic sigmoid all the way down, I said, okay, I think now, and with the recent 2 cases that were late diagnosis, I said, well, now I feel obligated to biopsy. But even in the biopsy, we saw this gigantic floppy rectum. But I would say in medicine, sometimes we are wrong. So I thought it was not Hirschsprung, but I felt the obligation to do a rectal biopsy. And I have to say, I usually don't biopsy. It's very rare that I biopsy a patient that has constipation only, because Hirschsprung is more than constipation. So the classic contrast enema for constipation, the presentation without malnourishment, without episodes of enterocolitis, it's very unlikely that it will be Hirschsprung. So we just thought it was good to put this case, since all the previous one were Hirschsprung, but this one was not. There's a question in the chat. It is important to take additional X-ray views during the enema. If so, could this protect 100%? The enema, we always need the lateral views. We have to do it slowly. So 100%. We have to tell a story with the contrast enema. So just an AP view is not enough. 100%. Any other comments?
Yes, I want to. the biopsy showed no ganglion cells and hypertrophic nerves. So I
Mhm.
would like very much to ask Dr. De La Torre to tell us how often do you see that and what's the meaning of something like that? Because this, particularly for young surgeons that are listening, what do they supposed to do if they get that kind of result? Of course,
Or it has
the goal
hypertrophic nerves.
they show hypertrophic nerves, but ganglion cells.
Yeah, yeah. This is a very common findings in patients with chronic idiopathic constipation. We have a study from 15 patients that we did a resection of the proximal rectum and the sigmoid, and all of them, they have hypertrophic nerves. This is a finding. This is the origin. We don't know, but it's a very common histopathological finding in patients with chronic idiopathic constipation.
Yeah,
We don't know why.
I think we are gonna start shaking the literature about hypertrophic nerves because when I saw this report, I had the same thought, and I agree. I look at the literature and I saw that yes, chronic constipation can have hypertrophic nerves. So if hypertrophic nerves can be present in chronic constipation, they are present in Hirschsprung disease, they are not present in some cases of long segment, they are not present in total intestinal aganglionosis or total colonic aganglionosis. Why do we give so much credit to hypertrophic nerves in the diagnosis? Is a question mark. So I think we're gonna be shaking the literature soon because I am afraid the hypertrophic nerve doesn't mean much. Okay, so we're gonna move to the next presenter, that it's gonna be Dr. Lore Galicia. She's a resident at Instituto Nacional de Pediatría. Welcome, Lore.
Thank you. Hi, my name is Lorelei. I'm a pediatric surgery resident, and today we present the case of a 3-year-old born to a 19-year-old woman who already had another son. In the medical history, she could not remember if the child passes meconium during the first 24 hours after birth, but since then, he needed rectal stimulation to pass the stool. We first met him when he was admitted to our institution because of a respiratory syncytial virus. And during this hospitalization stay, he developed enterocolitis with significant abdominal distension. So here we obtain a contrast enema that showed a transition zone at the level of the sigmoid colon and a severe enterocolitis proximal to it with an spiculated pattern. Here we took an abdominal X-ray 24 hours after the study was shown, the contrast enema, and we can see that there is retained contrast. So rectal irrigations were started on a regular basis along with oral metronidazole. We obtained a suction rectal biopsy that the result was aganglionic. So when the respiratory symptoms and the abdominal conditions improved, we took him to the operating room for a transanal proctocolectomy and a pull-through with full thickness anastomosis. In here, with the patient in prone position, we placed a long star retractor and we started the dissection leaving 1 centimeter above the pectin line. We got to the transitional zone and we did a full thickness biopsy, 8 centimeters proximal to it for an intraoperative pathologic consult that was reported normal ganglionic. So we extend the resection to a less dilated segment, completing the pull-through with a full thickness and anastomosis. The postoperative course was uneventful, and he was discharged 1 week after. The mother did not bring him for the scheduled follow-up visit, so he came back 1 year after the surgery with both enterocolitis and was again admitted to the hospital. Here we have an abdominal X-ray with significant colonic distension. So we started on IV antibiotics and rectal irrigations were done. When his conditions improved, a repeated contrast enema was obtained with a change in a diameter in the distal colon. Here are other projections of the contrast enema. We plan to obtain another biopsy of the descended colon to rule out a pull-through of a ganglionic segment, but the mother refused and they left the hospital against our medical advice. So again, he did not show up for clinical visits. He returned 2 years and 4 months after that event. He presented again to the emergency department with enterocolitis. So he was again admitted and treated with antibiotics and colonic irrigations. He persisted with dilatation of the transverse colon. And here we see 2 abdominal x-rays. There's 13 hours apart from each one. In this slide, we can see that the course of the abdominal conditions after 3 days of management with clinical improvement. And on this admission, the mother granted consent for the exam under anesthesia and a rectal biopsy was taken. The result was ganglionic cells present in both plexus and moderate hypertrophy. Upon the resolution of the enterocolitis episode, he was discharged home and returned to clinical 1 week later with fecal impactation. So this was resolved with enemas, and we started on Sina, but despite this 3 doses per day of 8.6 milligrams, he did not respond. So we started treating him with rectal irrigations. 2 weeks later, he was taken again to the emergency department with abdominal distension, dehydrated, and electrolyte imbalance. His nutritional status was really poor. He presented with hypoalbuminemia. And so when he was a little bit stabilized, we decided to perform an ileostomy. So we are uncertain if once he is derived, if the colon would improve or if we would need to resect the colon because of his dysmotility, even with normal ganglionic cells. In the hospital, out of 136 patients operated for Hirschsprung disease, we have had a clinical course like this only in 1 patient. It was with a classic variant that had colonic dysmotility with functional obstructions that ended up in colectomy as a rescue operation with Duhamel pull-through. So the patient had a favorable course after that, and we would like, if you could add advice from the experts of this patient, any feedback on our patient, what would you could help us to resolve it?
Thank you very much, Lori. I think this is a sad case because in this case, the patient had the diagnosis,
Yes.
had a beautiful operation, but patients with Hirschsprung disease, they do need follow-up. Even after a perfect operation, some patients will suffer from enterocolitis, other patients will suffer from constipation. And if you don't manage those conditions, then the patient will need more surgery. And it's very sad what has happened in this case. So if this patient was in front of me, I think I would leave this ileostomy until the mother has an agreement that she cannot lose follow-up. Otherwise, this patient will be back with you after you do this operation. And what you showed us is a patient that suffers from severe constipation and enterocolitis, has a massively dilated colon, characteristic of enterocolitis. So I think at this stage, the patient will need a reoperation, will need splenic flexure mobilization and pull-through. I would not do total colectomy. I would probably just resect more. And I think with mobilization of the splenic flexure and bringing the transverse down, it would be enough. But I would not reconnect this patient until this mother has proven that she will follow up. and that by scheduling multiple follow-ups, having her showing, giving her tasks. For example, if you redo the pull-through, having her practice irrigation just to prove you that she's now committed to follow up. Otherwise, I suspect this patient will suffer again. Do you have a comment?
Yes, I want to say that I didn't hear if you mentioned that the patient had a rectal exam. In other words, I'm sure you rule out first stricture of the anastomosis. Did you?
Yes.
They
Yes,
had no stricture.
no stricture.
Okay, so that's very important. And second, when I operated on Hirschsprung disease, I learned to resect not only the aganglionic segment, but to resect the most dilated part of the colon. Of course, you cannot end up resecting all the colon, but at least the most dilated part, I remove that because we know that any hollow viscous that is stretched, dilated, loses its peristalsis. The more dilated a viscera, the more inefficient becomes in terms of peristalsis. And then concerning the follow-up, I will tell you, when I work at the National Institute of Pediatrics, I had sometimes I had contacts with some police, and we send ambulance to the house of a patient to bring the patient and I was screaming to the mother, said, you come next week. So we handle the patients differently depending on how reliable the mother look. If the mother was not reliable, we used to keep the patients longer in the hospital. And also we threatened the mother, said, if you don't come here, we will go and get you. And I'm going to get the police and I'm going to accuse you of not taking care of your child. So we cannot do those things here, but in Mexico, I did those things. And I brought the mothers and I said, you better come and send the police to get the mother back.
Dr. De La Torre, any comment?
Yes. Loreli, how is the patient and the family and the mother with the ileostomy right now?
Well, at first, when we proposed the treatment, she started crying because she didn't want to get the operation. She told us that please give me one more opportunity. I would be like really applicated to the patient. I would be doing their irrigations, but after these 3 years and a half, we were sure that she wasn't doing the irrigation. So after that, we talked to her. We convinced her that this will be like the best procedure for the patient, and she accepted. The operation was done on Friday this past week, and right now she's getting the capacitation for the management of the colostomy bags, and I don't know. I think that she's more
And the
concerned.
patient, how is the patient? Is better?
Is better.
Yeah. So this is a social problem, and surgery is not going to change the social problem.
Okay.
So you can have this patient. I think the patient received a very good operation, but the social situation leads to this big problem now. It's not a surgery. So if you are trying to do a colonic resection or another colostomy or another pull-through or another ileostomy, whatever, always is going to be a social problem.
Yes.
So I think we need to address this problem with social workers, or I don't know. The other thing is the nutrition. So with the ileostomy and this social situation, you need to take care of this patient very close, because you already mentioned the patient has severe malnutrition. Now with the ileostomy and this social situation is probably going to be a very complex case now. Now, Botox, that many people is in the chat saying to use Botox, yes, you can use Botox. But Botox is not going to resolve the social problem, and Botox is just an adjuvant when you are doing irrigations or you want to transition from irrigations to enemas or transition from irrigation to laxatives. And remember, Botox is just the chemodenervation of the anal canal. In other words, the patient is going to be temporary, almost fecal incontinent, but
Okay.
you need to treat the patient with enemas or laxative, depends on the patient. And a new pull-through is not going to be, is not a good guarantee to resolve this problem. We had in the past many patients like this in Puebla with Carla, and we ended up doing a colectomy in a patient with the same clinical pictures. And we did an ileal pull-through, like a total colonic. And the patient went well. I am not saying that you need to do that, but we have a couple of these patients when Carla was in Puebla. Again, the social problem is not going to be fixed with surgery. Congratulations, Lorelli. A
Thank
lovely
you.
case. I love it.
Yeah, I would be very careful I know Dr. De La Torre didn't mention do a colectomy, but I just don't want the audience to get the impression that that's the recommendation. And ileorectal is it's when there is no ganglion cells in the entire colon, that's our option and that's the correct treatment. But when you have a ganglionated segment, I think this would be definitely my last resource because the long term of a patient with an ileorectal has several consequences. It's not a ride in the park either. So we have to be very, very careful. So I think any other questions from the audience or comments? I think those were very good cases, very interesting, very difficult. And I just want to thank everybody for joining us. Today we have 30 different countries: Chile, Algeria, Mexico, United States, Argentina, Peru, Pakistan, Brazil, Egypt, Kenya, Sri Lanka, Trinidad and Tobago, India, Russia, Honduras, Yemen, Czech Republic, Libya, Palestina, Colombia, Ecuador, Saudi Arabia, Cuba, Germany, Vietnam, Philippines, Myanmar, Turkey, Indonesia, and Nigeria, and Thailand. Oh my gosh, so 31. So thank you, everybody. Please join us next time. Send your cases so we can all learn from each other. Thank you. Bye-bye.